But now it is my great pleasure to introduce Professor Pierre-Hugues Roche, who is a professor of neurosurgery at the Medical School of Marseille in France. He's also the chief of the Department of Neurosurgery at the University Hospital of Marseille North and president of the skull base section of the French Neurosurgery Society. He's also involved in research activities on skull base surgery and spine trauma. Professor Roche, we are very happy to have you here today. Please go ahead.
Okay, Jennifer, thank you. It's a great privilege to be with you and to share my experience about this famous epidural approaches. To confess, I just during the 15 years previously, we operated in my department around 1,000 skull-base tumors and skull-base disease, and I must admit that the use of this epidural approach is extremely interesting and precious, and I would be happy to share with you today my view about the use of this approach, which means that we will go through the details of this of each of this approach regarding the technique, the indications, the limitations, the fields of applications. And this is a roadmap I propose to share with you today. This is an important issue to understand that these approaches are really different to the ones we were taught to, which means that the systemal approach gives you the opportunity to use the familiar anatomy and the natural corridor. Of course, the systemal approach are easy to go and easy to leave, but you have a lot of drawbacks, which means that you cannot control the bleeding very early in the surgery. You have usually the brain and the vessels which are interposed in between you and the tumor, and it's usually difficult to achieve a complete radical resection, which is sometimes interesting for the outcome of the patients. Conversely, using the petrosal approach, shorten the distances, allow you to devascularize the lesion first, try to limit the retraction of the tissues and the manipulations of the brain and the nerves, and allow you to achieve a better radical resections if needed. Of course, the interest is also to collaborate with the ENT surgeons who know a lot about the petrous bone anatomy, usually better than us, because they go routinely, daily in this petrous bone, and working with ENT surgeons is something which is really interesting. But the learning curve is very demanding. Sometimes the collaboration is not so easy. The procedure is sometimes longer. The bone work is sometimes difficult to appraise. And of course, each additional bone work will carry its own risk. Anyway, the use of this petrosal approach will allow you to mimic a skull top surgery for skull-base tumors, and which is the main interest. I guess you understand that easily. So, coming from an historical perspective, we have to understand that this approach has been developed both in Europe and in the US by ENT teams and by neurosurgical teams. You have here the Czechia approach here with Chandra Sen for cavernomas, which was developed in the early 80s. You have here a picture from Vinko Dolent in Ljubljana. Here, this is a picture with a triangular concept of the lateral skull base used by Taka Fukushima, and this is a dissection from Chandra Sen. And you see that it comes both from the US and from Europe at the beginning of the 80s, and each of them, they developed their own way to go to the tumors. And I have to mention the name of Hugo Fisch from Zurich and the name of House and Brackman from Los Angeles, who developed interesting ways. But things changed a lot during the last 15 years. because we were able to assess much more our complications. We understood much more the tumor biology, and now I would not say routinely, but targeted therapy play a role in the treatment of some tumors, and we have a lot of hopes using this kind of targeted therapy in cavernomas and even in some kinds of meningiomas. So it changed. The quality of life was better assessed than in the past, coming from the patient's opinion and not only from the surgeon's opinions. And we have, of course, alternative techniques who emerged, like endovascular techniques and, of course, radiosurgery, who changed the paradigm in the way we treat the patients. And just, if you remember, we operated all the acoustic schwannomas. Today, to be honest, I offer the radiosurgery for the patients with small and middle-sized acoustic, and I do not longer operate them anymore. So it changed a lot. We had endoscopy who also came during the last 15 years and who took advantage for extradural tumors and who limited gradually the place for the skull-based approach, the regular one. And we are moving much more toward functional sparing skull-based surgery instead of radical big approaches who are sometimes a little bit harmful for the patients. So would I say that endocranial and endoscopic approach are adversaries? I would say, of course, not, because there are respective indications for both of them, and they are probably partners. And in the hands of the skull-based surgeons, it's interesting to learn both. Coming from the nose and coming from the endocranial will offer you both ways to manage the patients. If we look at what happened in the previous year, this is a paper published in the Neurosurgical Review showing the tendencies of each of these approach. You see that this is on the blue at the bottom of the window. You have the growth of the endoscopic approach, and other approach were gradually decreasing. So sometimes, if you look at that, I like this Scott's parabola, who was published years ago in a very famous journal, who indicate the reasons why some approach who grew up, who were popularized, suddenly decreased, and were probably sometimes reoriented toward other targets, but other ones disappeared. If I take the example of the transcochlear approach, transcochlear is an extended petrosectomy in where you had to mobilize the facial nerve. You have to translocate the facial nerve. You had to destroy the cochlea and the labyrinth. And this is not a conservative approach. And this approach was dedicated to the petroclival area. But if you look at the bone work that is done here, this is extremely demanding and harmful for the patient. If you just look at the facial nerve results with the transcochlear approach, mostly the patients recover to a grade 3 House and Brackman deficit, which is not a good facial nerve result, just because you mobilize the facial nerve inside the petrous bone. So these kinds of approach disappeared from our armamentarium. Today, it's over. I don't operate anymore any patient using the transcochlear approach. So if I move to the approach I would like to go through today, the principal pillar of the approach I would like to go through is the anterior petrosectomy. But you can see that the anterior petrosectomy can be combined with a more anterior approach like transcavernous, or conversely can be associated with the pre-sigmoid retrolateral lab approach, which is called the combined petrosectomy. And I will go through these three kinds of approach with you today, just to show you that this is the target you have when you remove the anterior petrous bone here. So if you take a petrous bone from the top, and if you unroof the right petrous bone here, I just unroofed here. You see here that this is the anterior petrosectomy, which is here. You can see once you have unroofed the cochlea, the complexity of the internal auditory canal, the first portion of the facial nerve, the geniculate ganglion, here in the Makel cave over there. And coming from the back, you have this regular anatomy with the mastoid antrum here, the semicircular canal. And I think this is important to have this view, just to understand that you have to combine different corridors to achieve a proper petrous bone resection. So This is the lateral approach. I told you that this is the main pillar of my approaches. And usually this is the kind of skin incision I offer to the patient. This is a regular standard temporal squamma resection here, the bone flap with only one burr hole just above the posterior root of the diagoma here. The next step is to elevate the dura toward the rhomboid construct. And the rhomboid construct is delimited by the groove of the superior petrosal sinus here, the arcuate eminentia on the right, and the GSPN over there, and the posterior wall of the V3. And this rhomboid construct is the landmark that you will have to drill through in order to remove properly the petrous bone. While you will achieve that, you will have to manage properly the dura here, and I draw you the different cuts of the dura above and below the superior petrosal sinus in order to cut transversally the tentoria all the way to the fourth nerve here. And if you have done that, this is what you have to see. Once it's achieved, this is a fantastic approach to the ventral and lateral part of the pons here. You have at the bottom of the field the ICA and the acousticofacial bundle, which is one of the limits of the approach at the bottom. And you are just centered at the level of the trigeminal nerve. And this is pure beauty to manage this trigeminal nerve in this way. And the pure beauty of this approach is to be able to combine that with the Makel cave approach. You see, this is a meningioma on the right side here. This is a trigeminal nerve in the white part here, and we dissect the porous trigeminus, and we can cut, like in this kind of cadaver head dissection here, we can cut the ring of the porous trigeminus in order to expose what's inside the Makel cave here. At the bottom of the field, you have here the basilar artery with the ICA and the lateral part of the brainstem, the pons. I showed you that previously. This is the pons. This is the trigeminal nerve. The sixth nerve is coming toward the Dorellos canal. This is the basilar artery, and we left intentionally a piece of tumor at the level of the brainstem. It was, by the way, a meningioma here. So this is the anterior petrosectomy. Sometimes you have to combine with the Dolenc approach, which is called the extradural anterior clinoidectomy, which will give you the opportunity to manage both the cavernous part of the tumor and the part which is in the petroclival area. So briefly speaking, you have different of skin incision here. You can go through the FTOZ. Usually I don't need to use this kind of FTOZ, which is a little bit harmful to the patients, but I prefer regular pteronal approach here. And then you go through the anterior clinoid process resection. The key point is to see the meningoorbital band here, the grid sphenoid wing over there, and the dura of the frontal floor here, and you elevate gradually, epidurally, the dura around the anterior clinoid process, the ACP, to unshave the optic canal, to unroof it, and you remove en bloc the anterior clinoid process. You can see here, this is the end of the ACP resection. You have over there the clinoid process, like a shark tooth here, and you have the optic canal over there, the paraclinoid space here, and now you can go through the anterior petrosectomy. You can elevate the dura propria from the lateral wall of the cavernous sinus. If you need to enter inside the cavernous sinus, usually with meningioma you don't need to do that, but with chordomas and chondrosarcoma, there is sometimes a need to go inside the cavernous sinus. And the beauty of this approach is to combine a cavernous sinus approach plus a petroclival approach, which is beautiful. At the end of the dissection, this is what you obtain here. You can enter into the cavernous sinus through the Parkinson triangle, and you can, of course, manage what's inside the petroclival area. You can see how fantastic in this corridor in this case. So the other way to combine the surgery is to associate the anterior petrosectomy with a posterior petrosectomy. And if you use a segmentation of the petrous bone view from the top, in this way you will remove the mastoid you will remove the petrous apex here, and you will leave the labyrinth here. This is the key. The key of the combined petrosectomy is to be very conservative. This is a big approach, but this is a very conservative. So if I go through the resection, this is what I showed you. This is a resections you do gradually. The patient is positioned this way. You have this kind of complex skin incision here. You need to be very clean to elevate the soft tissue superiorly here. This is very clean. The patient is now, the surgeon is positioned behind the head of the patient, like how doing the ENT surgeons. I will show you through details later. And this is a mastoidectomy. And this is what you can see here, the mastoid antrum, just to skeletonize the semicircular canal. You have to skeletonize. You can see the blue line of the posterior semicircular canal. This is here the superior semicircular canal, the lateral one, and you can unshave the second portion and the third portion of the fascial nerve. Once it has been achieved, you need to do your bone flap, going through the occipital and the temporal bone here. And this is what you have at the end of the surgery, at the end of the exposure. This is a bone flap crossing, you know, the transverse sinus on the right side. And you expose all this kind of dura. So this is a big approach, but still, this is a conservative approach because you don't have to mobilize the fascial nerve. You remember the transcochlear I told you recently, and you preserve also the semicircular canal. And you can see in this right bottom panel here, this is what you obtain after the surgery. At the end of the surgery, you have removed all this piece of bone, petrous apex, plus the mastoidectomy here. And this is pure beauty to have that. So about the fields of application of these three respective approach, of course, it depends on the goal of the surgery. Of course, should you go for radical resection? Should you go for the biopsy or subtotal resection? It depends on the location and the size of the tumor itself. It depends on the patient's conditions. Don't harm the patient. If the patient is severely disabled, go through a systemic approach. Try just to decompress, to debulk the tumor, but don't harm the patient with lengthy approach. Of course, the team experience is needed. This is important. So sometimes you will operate regular disease using the skull-based approach, and you will, for example, use an anterior clinoid process resection to remove this, to clip this giant ophthalmic artery aneurysm here. And sometimes you will use this approach also to remove cavernomas, brainstem cavernomas. In these patients, I use an anterior petrosectomy to remove this cavernoma here. So this skull-based approach can be used for regular disease, not only for skull-based disease. And sometimes, of course, mostly you will use this approach for skull-based disease. This is an epidermoid cyst of the petrous apex. This is a meningioma. This is here a cisternal epidermoid cyst. This is a cavernoma I told you. This is another one. And this is a dumbbell-shaped trigeminal schwannoma. So indication you see are very different. I will show you how we can resect here an epidermoid cyst through an anterior petrosal approach. On the left side, you see here you are removing. This is a basilar artery. This is here the lateral portion of the brain of the pons here, and the beauty is to be around the trigeminal nerve and around the sixth nerve, which is pretty much difficult to have when you are operating using a regular approach like a retro-sig approach. You see here, this is a sixth nerve, and you are exactly very shortly placed toward, just in front of the sixth nerve here. You can see the beauty. The sixth nerve is over there, and you can remove the last piece of the tumor here using that. We are medially to the trigeminal nerve here on the left side. You see, you can translocate a little bit the trigeminal nerve, and more than that, you can control both trigeminal nerve. You can go behind the basilar artery, which is really difficult to achieve with the systemic approach. We have the other fifth nerve here. You see, this is the fifth nerve on the other side. Because this is a lateral view. Well, if you use this approach for epidural tumor, this was a chondrosarcoma on the midline. The patients came with the diplopia. With the sixth nerve palsy on the left side, on the right side, sorry, we are on the right side, of course. This is the bone flap I told you. We elevate gradually the dura here, and I will show you the details of this approach. Important landmark is to cut the middle meningeal artery at the level of the spinosum foramen. You coagulate, you cut it, you elevate the dura, and then you will identify the foramen ovale here with a stimulator, and here you elevate the dura to identify the geniculate ganglion. And you see here we are dissecting around the GSPN, and we identified the rhomboid construct I showed you, and we drill underwater with a diamond drill inside. And this is an epidural approach here. You see the typical texture of the chondrosarcoma. This is the last piece of the tumor here. This is what you can remove with ring carets. This was a chondrosarcoma. This was an epidural tumor. Of course, you can use an endoscopic approach, but you can also remove mostly the tumor using this epidural approach. And to be honest, this is not an invasive approach. This is really a conservative approach. In this way, we cut the dura of the tentoria here. This is a tentorion, and we cut it all the way to the fourth nerve, and we could manipulate the tumor inside. And we are in the petroclival area, but I cut the dura of the clivus here to push the tumor and to be able to. You see here you have the fifth nerve, which is here. You have the tumor, the jelly texture of the chondrosarcoma, and this is the fifth nerve over there. And really, this is really elegant to be able to remove all this tumor by just suction and ring carret using this approach. And my opinion is this is really a conservative approach. So I will not go through all the length of this video because of the time. I will move to the next one. This one is really interesting. This is the possibility to associate transsylvian and transpetrosal approach, which this is what we call the half and half. You see this meningioma here. This is a giant one, and the tumor is going up above the posterior clinoid process, and is going down all the way to the lower clivus. And here is the roadmap of what we have to do. Sorry, this is in French, but anyway. You have an extradural step, you have an intradural step, and this is a bone flap on the left, bigger than an anterior petrosectomy because you have to go transsylvian. We do the same than previously. We identify the meningoorbital band. We coagulate here, and of course here, this is the rhomboid construct. You can see here, yes, this is the V3, this is a great petrosal nerve. This is arcuate eminentia rhomboid construct, which is drawn in a dotted line here. And we will drill here. So we started with the petrosectomy first, and then you will see that this is a little bit lengthy, but we achieve the petrosectomy on the left side. It's important to have a clean field and to usually use hemostatic agents and oxycellulose or all hemostatic agent to have really a clean field, because you don't want to have some bloods inside. And then once the petrosectomy is achieved, I decided to go anteriorly and to skeletonize rotundum, of course ovale, I told you, and to make sure that you will properly achieve then the other step of the approach, which was the ACP resection. And once it's done, we could open the dura at the level of the sylvian fissure and at the level of the antepetrosectomy. And this half and half approach allow you to, going from the top, remove the part of the tumor which is at the level of the carotid artery and at the level of the sylvian artery and optic canal. You see here, this is the opening of the dura toward the sylvian fissure here. Okay, we remove the ACP, and here you can see the key. The key is really to relieve to release the CSF. We open the perioptic cistern here, and we expose the carotid artery and the chiasma. and the optic nerve here. And this is the anterior part of the debulking of the tumor. Hopefully, we were lucky enough to have a soft tumor here. This is the opening of the Sylvian fissure, working in between the different corridors, between the carotid artery and the third nerve. And you see the third nerve here. This is the manipulation of the third nerve, and then working between the carotid artery and the optic chiasma. So in this kind of extensive half-and-half procedure, you see how large is the field here, and this is at the end of the procedure. You have the third nerve, the carotid artery, and if you combine this approach with the petrosectomy here, you open the dura. We did what we always do. We coagulate the dura of the superior petrosal sinus. You see we are above and below the dura and the tentorium. We cut the tentorium transversally all the way to the fourth nerve, which was seen here at the bottom of the field. And you make communication between the petroclival area and the maple cave. And I decided first to go from the top and then to finish with the lower part of the tumor. And at the end of the surgery, putting fat with glue is really something very important. So you see here the surgery, the final step of the surgery, the petrosectomy, the bone flap here, and this kind of surgery allow you to manage properly this double compartment tumors, which was involving the carotid compartment and the basilar compartment. So think about the half and half. You can combine the petrosectomy with the Sylvian approach. So here we have a chondrosarcoma, which is involving altogether the cavernous sinus and the petrous apex on the right side. And this is a ACP. This is not an ACP. This is a petrosectomy and a transcavernous approach. So here we are between, on the right side, between V2 and V3 here. We resected the Mulan triangle, the anterolateral triangle. This is the elevation of the dura propria from the lateral wall of the cavernous sinus. And in this approach, we aim to remove the intracavernous compartment and the petrous apex compartment of the tumor. So we are here between V2 and V3, cavernous sinus is over there. Here we are the petrous apex, the jelly gray, soft, typical component of the chondrosarcoma here. This is a resection of the tumor, which is usually ill vascularized with the ring curette. And look at what we can obtain in this case. This is a carotid artery at the level of the petrous apex, and now you can open the cavernous sinus in between the fourth nerve and V1, what we call the Parkinson triangle. This is the view of the intracavernous component of the tumor through the Parkinson triangle. Fourth nerve, V1, extraction of the tumor, and you can manipulate the tumor alternatively in all the compartments. You see cavernous sinus, V2, V3, petrous apex, intracavernous tumor, part of the tumor. So think about the possibility to combine the petrosectomy plus a transcavernous approach. I would go through the posterior lateral approach, which is called the combined petrosectomy. And I told you how demanding this approach. You will see this is something I usually do with my ENT surgeon, a colleague, Professor Lavier, who is an orthologist. And this video, we did it with Dr. Luca Trude, which is one of my collaborators. This is a petroclival meningioma. And the way we used it was because the tumor was going through the lower clivus. So we are on the right side. This is the retrolab approach. Neurosurgeons need to know about to do that. Of course, ENT are doing that routinely, but please be aware that if you want to become, I would say, a regular neurosurgeon in the skull base, you need to be able to do that, to skeletomize the semicircular canal here. You see the dura, we remove the bone flap, transverse sinus, sigmoid sinus, semicircular canal, elevation of the dura from the floor of the middle fossa. And we are here now skeletonizing what we call the P2 apex here. Okay, this is the rhomboid construct, always the same. Arcuate eminentia, superior epidural sinus, V3, GSPN, and you have to drill in between all these compartments. Once you have finished, clean field without any blood, and then you can open the dura. So opening the dura is pretty much complex in this situation. You have to open above and below the superior epidural sinus, of course, cut the tentorium. You see the trigeminal nerve here. And using the combined petrosectomy will allow you to manipulate behind the tumor and above the tumor. This is why it's really very interesting. This is a porous trigeminus. I already told you that you can manage what's inside the Meckel cave here. You see this kind of ring, dura ring, you cut it, and then you will be able to put into communication the Meckel's caves with the trigeminal nerve in the posterior fossa. We are in between the fourth and the trigeminal nerve here, and now we are behind the acoustico-fascial bundle and the lower cranial nerves. And this approach is interesting when the tumor is growing, extending toward the CPA and towards jugular foramen. Usually for regular petroclival meningioma, I use an anterior petrosectomy. But with this kind of tumor, you need to make a combined petrosectomy. Of course, it's much more demanding than the regular antepetrosectomy. But you see the basilar artery, the sixth nerve here, and in this case, you have to leave some piece of tumor. If you see the fourth nerve, we are manipulating the fourth nerve. If you remove the tumor at the level of the tentorial notch, at the petroclinoid fold, you will have a permanent deficit of the fourth nerve. So we are now at the end of the surgery, and you can see that from the third nerve to the 11 nerves, and you can see all the anatomy. Closure is important. Watertight closure of the dura is impossible because you remove the dura. So you have to put fat inside. You see the piece of tumor we left at the level of the clivus here. So leave some piece of tumor because gamma knife is working nicely for this kind of remnant. You don't need to remove everything. So if I look at our experience, it was a collective paper, multicentric retrospective paper in our experience with other colleagues from other cities in Tours, in Grenoble, and in Angers. This is the patients we had to manage together, and this is you can see how all the approach we used. We used so many different approaches. Usually the approach we used was depending on the expertise we had. If you are familiar with the retrosig approach, of course you will use the retrosig. But if you can be able to use all the approach, all the armamentarium, you will change the approach. So drawbacks and limitations. Well, if you look at the petroclival meningioma, look at the complexity of all these tumors. These three tumors are petroclival meningiomas, okay? You can see that, but they are totally different. The easier one is probably this one to remove, okay? Because you can remove easily the tentorial part and decompress the branchium. This one is much challenging, and this one is obviously the central petroclival meningioma. It's probably impossible to remove totally. So this is what we did in our experience. You cannot achieve complete resection in all the cases. You have to interrupt the surgery and leave some piece of tumor in order to avoid any damage of the nerve. And usually you need to offer adjunctive treatment. So this is what we did. This is the complications you have. Of course, you have to tell the patients, well, there are complications, there are drawbacks, there are things that will be due to the manipulation of the tumor, the fourth nerve, the sixth nerve, but sometimes this is what you have. In this case, you can expect what happened, the decreasing of the evoked motor potential in this case, and we manipulate the posterior cerebral artery, and we got an infarction on the left midbrain, on the right midbrain, which is a disaster, of course, for the patient. This is because we did not interrupt the surgery at the time of the dissection of the posterior cerebral artery. Is it easy to predict the complication? Not so much. There are studies published by Kawase Group, for example, who predict the ability for the resection and the morbidity of the patients with the classification of the location of the tumor here. And this is extremely helpful, but it's not always reliable. This is the way we could predict our complications. It's now under submission in a journal, and will be published very soon. But selection of the patient is the key. If you do not select properly the patient, particularly the ones who are still eligible, who are not severely disabled, expertise is something which is very important. You can see that the number you reach is important to avoid the complications. So expert centers will have better results than the ones who are operating 1 or 2 cases a year, of course. This is important. So I already put you these slides just to check the importance of the indications and the advantage and drawbacks of the cysternal approach versus the petrosal. You see this meningioma on the left side, at the right bottom here. Of course, if I show that to expert neurosurgeons, probably 20% will go through an endopetrosectomy and 80% will go through a retrosig approach, and both of them will be okay. I can accept going through the retrosig approach in this case. Of course I can. Maybe the thing which is important is that the burden of the transtemporal approach. If you elevate the temporal lobe here, I already mentioned this complication, but this one is something which is very important. If you elevate the temporal lobe, even though you are very conservative and very meticulous, due to the possible interruption of the venous drainage at the level of the temporal base, sometimes you have these edemas of the temporal lobe. Last week we operated a trival meningioma. We manipulate a little bit the veins indirectly because we did not see even the veins, and the patient is still display some aphasia. Of course it will come back, but sometimes you have that because it's really important to check beforehand the venous pattern of the drainage of the temporal lobe. You see in this case, this patient, look at that. This is a patient which is perfectly eligible for an endopetrosectomy, but look at this drainage here. This is a drainage at the bottom of the field, just at the level of the elevation of the dura. If you do not manage properly these veins here, if you do not preserve that, if you interrupt this venous drainage, as illustrated in this GNS publication, this is what you have. You have a contusion. This is not because you directly harm the temporal lobe. This is probably because of the venous interruption of the temporal lobe here. So the key message, education is the key in the lab, of course, not with simulators. Simulators, high fidelity simulators is difficult to have in neurosurgery. We know that. We have the NeuroTouch, we have these tools, but working in the lab is the key. Selection of the patient is mandatory. High quality assessment of your own results, not the ones of the literature, but your own results. Honestly, this is something which is important. Remember that each approach carries its own risk. Each piece of bone you will remove additionally might damage, harm the patients. You don't have to always climb the nose face to go to the top. Sometimes you can adopt a regular, conservative approach. There is no need to go through the nose face. And of course, you have to consider for other options. If I look at this patient, I did not operate this patient. He was 82. I told him, okay, come on, let's live. Let's live with this tumor. At that time, he was not severely disabled. Gradually, he deteriorated. You can see the growth of the tumors 5 years later on. I put him a shunt, and he was happy with that. I gave him some steroid, and finally, 5 years later on, this patient died because of the complications of the disease with lower cranial nerves problems. But at least he experienced 5 years with excellent quality of life. And he was 82 at the time I managed him. He died at 87. Okay, if I had to operate this patient at 82, perhaps I would have had to give him some deficit, and which is not acceptable. So wait and see is always an option. Don't forget, for benign tumors like meningioma, this is an option. And sometimes, and this is my last slides, You can go through regular approaches. Look at this lateral wall cavernosinus meningioma. The incision is very tiny. There is no need to go through a complex half and half approach in this case. Just regular Transylvian approach, like is shown here. You can see here. This is a posterior climate process. This is the incision of the tumor here. The tumor gave space for you in the Sylvian fissure. There is no need to offer FTOZ or all this kind of complex approach. Just go through intradural approach. Sometimes this is something that is very helpful. So do not harm the patients. Be able to alternate with complex approach, more conservative approach. Think about the radiosurgery. Sometimes it's helpful. And this is what I wanted to share with you this afternoon. And I really thank you for attention.
Thank you so much, Professor Roche, for this very passionate and fascinating insight into your work. We will be coming to the questions in just a moment, but let us take a look at the supporting Leica technologies for skull-based surgery. Those are the Arvio Digital Augmented Reality Microscope, the M530 OHX Surgical Microscope, and Glow 800. Dear viewers, dear audience, if you would like to learn more about these technologies, you are more than welcome to request your private session by the Leica experts. You can see on the slide that there are numerous options available, so please do not hesitate to reach out to Leica. And now I would like to thank you for your questions that you submitted that we will now be taking a look at. So, first up, Professor Roche, our audience would like to know, what an amazing demonstration of brain anatomy knowledge. I could not agree more. Using this approach, do you use or recommend to use the microscope and partly the endoscope?
Okay, this is an excellent question. This is, in my experience, a pure microscope. Surgery is done under microscope mostly. I can understand that endoscopically assisted surgery is helpful if you want to go around the corners. And there is an interest probably if you want to remove this, for example, this epidermoid cyst in the around the corner. The use of a 30-degree endoscope is probably useful as an adjunction to the microscope. But mostly, using the petrosal approach, there is no need to put an endoscope in. If you want to put an endoscope, it means that you will use probably a regular systemnal keyhole approach, and you will be assisted by the endoscope. And in my experience, going through the petrosal approach give you enough maneuverability to tilt the microscope in many ways, many angles, and avoid you to use the endoscope. So I acknowledge that there is some interest. Remember the epidermoid cysts around the corners, but in my experience, I don't use.
Okay, thank you so much, Professor Roche. Then let us take a look at the next question. Dear Professor Roche, are you performing all those surgeries without AR or VR tools, neuronavigation, fluorescence, Glow 800? What would be the advantage for the use of them or not?
Oh, thank you for the questions. I appreciate. Sometimes it's, of course, we navigate. We use navigations, and there is something which is very helpful is to navigate the focal point of the microscope. If I navigate the focal point of the microscope, I don't have to put any tool inside to check where I am. So this is what we are doing routinely, particularly at the step of petrosectomy. If you are not far from the fascial nerve or the semicircular canal, navigation of the microscope is something very useful. It's, of course, very useful when you have to educate young neurosurgeons because you confirm your feeling and your expertise to what is given by the navigations, and you know that navigation using the landmarks of the bone windows. One bone window CT scan is very reliable, and I always advise my young collaborators to check at the bone windows of the petrous bone, and you see how you can confirm your surgery, your drilling, and where you are really. So for navigation, this is really useful. Fluorescence, I routinely use the ICG to check the patency of the vessels during the surgery. I usually use that both with the microdopplers for the arteries, but for the veins, if you want to check, I usually inject the ICG, and it's very useful. Yes, but it's not really virtual reality. I used it in another department. This is augmented, a little bit augmented, but it's not virtual reality. Navigation, ICG are part of my routine, I would say.
Okay. Thank you so much. Then next, our viewers would like to know from you, regarding the dissection part without using the microscope, what is your opinion about using your microscope as an exoscope for teaching purposes?
Yeah, of course. I would say that there are parts where the microscope is absolutely needed, particularly when you are in a deep field, when you need to have more light and more magnifications. But at the beginning of the surgery, usually I do all the superficial steps without any microscope, of course, because we don't use it. I'm not sure that using the microscope as an exoscope gives you additional value for the teaching purpose. You can directly explain to the residents, we are around you, we scrub with you in the OR. So I won't use it in this way, and I just use it on purpose when there is a need for the patient itself.